Thank you again for bearing with us, getting just a couple minutes behind, but we will do our best to make up that time so we can finish right on time. And our webinar this morning on exploring comprehensive diabetes prevention and care in Oregon. This webinar is part of an ongoing public health and primary webinar series featuring public health experts who can offer valuable training and resources to primary care providers and examples of how the two can work together to improve population health. My name is Valley. I'm a facilitation and improvement specialist with Oregon Quality Corporation, and today I will just be helping to moderate the webinar. Our presenters sort of the reins because they have a lot of and wonderful stories and things to you. We ask that you please submit any questions that you have at the time to the questions panel or chat panel. And to the right of your screen, there's an image here for the Q&A. If that blue bar for Q&A isn't showing up, you can hit through the top question mark symbol. Time set aside to take your questions after each portion of the presentation, but again, please feel free to ask questions at whatever time they happen to come to you. Yet is whether or not the web recording and slides will be provided, and yes, they will be made available on our website from the webinar today. The Patient-Centered Primary Care Institute. So the Institute is a public-private partnership that was launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation and managed by QCorp. Together, we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they towards the patient-centered primary care home or medical home model of care. We work at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to visit our website at www.cpci.org to access resources, including previous webinars, and sign up for our email list on the website, which is how we will announce additional web-based and in-person training opportunities, as well as our institute programs. The Institute aims to help primary care practices achieve recognition as a primary care home through Oregon's Patient-Centered Primary Care Home, or PCPCH, program. The model of standards organized under 6 core attributes, which you see here, and you can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. To introduce to you our wonderful panel of speakers, and as soon as I do that, I will turn things over to them. On the phone here, Dawn Kane. Dawn is a registered dietitian and certified diabetes educator, as well as a master trainer of lifestyle coaches for the National Diabetes Prevention Program, DPP. Donald Schnitzer Diabetes Health Center, HSDHC, 2008, where his work has a clinical and community outreach focus. Since 2018, the HSDHC, the Health Promotion and Chronic Disease Prevention, HIP Connection of the Oregon Health Authority Public Health Division, have been working closely to scale the national DPP in Oregon. Welcome. We also have Tracy Carver on the line. Tracy is the Oregon State Lead for Medicare's Everyone with Diabetes Counts initiative and the Integrating Self-Management Education into Patient Care Special Innovation Project. Acumentra Health. Tracy worked for the Oregon Health Authority and was part of the state team that established the Stanford Chronic Disease Self-Management Program in Oregon. And 8 years of experience leading innovative quality improvement and population health initiatives, and Tracy's career is focused on working with Oregon communities to design systems that improve chronic disease management and self-management support to health disparities and improving medication safety. She experienced in working with a broad range of stakeholders and facilitating diverse organizations with a common aim. She has a public administration degree from Portland State University. And then we have on the line today Sarah Worthington. Sarah the Healthy Communities Coordinator with Deschutes County Health Services since July 2014. She is the leader and coordinator for Stanford's Diabetes Self-Management Programs in the Tri-County region of Central Oregon. Sarah is a lifestyle coach for the Diabetes Prevention Program, DPP, and partnered with 2 primary care clinics to bring the DPP to Central Oregon, launching their first cohort in January of 2016. I want to hearty welcome and a tremendous thanks to all the work that our presenters have put into this presentation. And as you can hear, they are very well experienced in this topic, and you're in good hands to be hearing about all of these programs happening in our state. So I will turn things over to start us off.
Verifying that, Rebecca, you can hear me. We had some technical difficulties this morning. I'm very pleased to be here with you. The objectives for our conversation today, this presentation, hopefully folks will be able to list the components and goals of the Diabetes Prevention Program, state the how for screening patients for diabetes, and actually differentiate between the DPP, the Diabetes Prevention Program, Diabetes Management Education, and our Diabetes Self-Management Program, and describe the critical role that patient-centered primary care homes can play in referring high-risk patients in Oregon to the DPP or Diabetes Self-Management Education or the Diabetes Self-Management Program from Stanford. I'd like to begin the conversation by actually kind of framing what's going on nationally and in the state of Oregon relative to diabetes. I think, as everybody on the phone knows or on the call knows, diabetes challenge with people across the country and the state of Oregon. And we're looking at 29 million people with diabetes, and we look below that 20 with diabetes, we're looking at people in the United States with pre-diabetes. And so that's a challenge that we're all going to be faced with, both economically, if all of these 86 million people transition into the type 2 diabetes. We have about 1 million people in the state of Oregon with pre-diabetes, and we're looking at about a third of U.S. adults having pre-diabetes, half of U.S. adults over the 65 actually having pre-diabetes. And if we look at these 86 million people with pre-diabetes, 30% of these people will develop type 2 diabetes within 5 years if no action is taken. So a potential big problem board in the state and across the country. Happening in Oregon relative to diabetes. 287,000 adults in Oregon that have diabetes. About a million in Oregon we think have pre-diabetes. The important thing here is that people with diabetes, in addition to being at risk for problems with eyes and kidneys and nerves and feet and so forth, which are people are very fearful about, people with diabetes are 2 to 4 times more likely to have heart disease and stroke compared to someone that doesn't have diabetes. Diabetes disproportionately affects with less than a high school education and certain ethnic minorities, including African Americans, American Indians, Alaska Natives, and Latinos. So just so we're literally on the same page in terms of the numbers, diabetes can be diagnosed with either a fasting plasma glucose, a hemoglobin A1C reading, or a glucose tolerance test. In most clinics, diabetes is diagnosed, and hopefully pre-diabetes is identified with either an A1C or a fasting plasma glucose. So with this slide, you can see that the pre-diabetes range for A1C is between 5.7 and 6.4%. Looking at the next to the A1C, pre-diabetes is identified with a fasting blood sugar between 100 and 125. So anybody that develops type 2 diabetes actually moves through a stage of pre-diabetes. The problem is a lot of people either aren't tested or are not potentially told by their provider that it's not a big deal. And the good news is that the transition from pre-diabetes to type 2 diabetes can be halted or slowed with a lifestyle intervention. A little bit more framework relative to diabetes. Why is there so much diabetes in the United States? I don't think it's a secret to people as a country we're heavier. And these are CDC graphs that a lot of people are probably familiar with. The CDC graphs just show over time the prevalence of obesity in the United States. And too deep into this slide, as the get darker, the amount of obesity rises. And if you look at the diabetes part of this slide, as it gets darker, the incidence of diabetes increases. So as we get here, we're seeing more and more diabetes. What we'd like to do today is talk through 3 primary programs where people who either have pre-diabetes or diabetes can go. The prevention program is a CDC-sponsored program that lasts for a year and is designed for individuals with pre-diabetes. Management education is something that usually is delivered over the course initially of about 10 hours, and it's comprehensive self-management designed for individuals with a diagnosis of diabetes. Examples of diabetes self-management education would include blood glucose monitoring, advice on healthy eating, physical activity, discussion of medications, and the sort of coping with a diagnosis of diabetes. So if someone is new onset type 2 diabetes, it'd be wonderful to get them into diabetes self-management education. For diabetes self-management program is an evidence-based, peer-supported self-management program for people with type 2 diabetes designed to help participants gain confidence in symptoms in the day-to-day self-management. Sequentially, we'd like people who are new with diabetes to first get some diabetes self-management education under their belt, and then once they've got that initial diabetes self-management, the fundamentals, we'd like to transfer or transition over to some form of support. And the Stanford program, which we'll hear about today, is a wonderful way for participants with diabetes to get support in care of their self-care behaviors. What it shows is just a breakdown in the form of a table of the 3 programs. So the diabetes prevention program is aimed at people with pre-diabetes. The goals are twofold. One is losing 7% of their body weight, and the second goal is achieving 150 minutes of physical activity. Program leaders can be lay people or healthcare professionals. We'll get into this a little bit more as we talk through the DPP. Management education is kind of designed for people who are new to diabetes, or maybe their diabetes isn't that well controlled, or they're a refresher on just some of the fundamentals related to self-care with diabetes. This management education is traditionally administered by a healthcare professional, a lot of times a dietitian, a nurse, maybe a pharmacist. These are all people that are licensed and have healthcare profession in their background. The self-management program skills for daily self-management, increase patient activation, self-efficacy, and promotes effective communication with the healthcare team. So the diabetes management program is more of a support system. Conversations take place with patients to get them confident in their ability to manage their diabetes. The people that delivered the Stanford program are certified leaders. They have to have gone through some formal training, and it may be a peer who has a chronic condition like diabetes, or it possibly could be a healthcare professional. So when we talk about diabetes, one of the primary goals of this webinar is actually to get people at the primary care level thinking about screening people for diabetes. And so who should be screened? According to the American Diabetes Association, people over the age of 40 should be screened automatically, especially if their BMI, their body mass index, is greater than 25. If that screening is normal, someone should get screened again in about 3 years. However, we don't have to wait until someone's 45 to screen them for diabetes. We encourage screening earlier if the BMI is over 25 and they have one of these characteristics. They're physically inactive, they have a first-degree relative with type 2 diabetes, meaning mom, dad, brother, sister, someone along those lines. If they're from one of those high-risk ethnic groups and they're carrying some extra weight, they should be screened for diabetes, pre-diabetes. They have hypertension or altered blood lipids. They have a history of cardiovascular disease. They have a history of PCOS, polycystic ovary syndrome, history of gestational diabetes or a baby weighing greater than 9 pounds, and of course, a previous diagnosis of pre-diabetes. Someone should be screened for type 2 diabetes. These are other things that contribute to the risk for developing diabetes. These are clinical characteristics, and they just happen over time. So, family history of diabetes, they're high risk. As people are older, the risk increases. There are risk ethnicity groups, people that are carrying extra weight are at high risk, people who are inactive are at high risk. And this is some of the clinical markers, HDL and high triglycerides, hypertension, coronary disease, peripheral vascular disease, again, that gestational diabetes, PCOS, or pre-diabetes. All of these things should be kind of flags that maybe we should do a fasting blood sugar on this patient, maybe we should do an A1C to see where their blood sugar is. Okay? So that was just a little bit of overview of the specifics we're going to get into today, and I'm going to go ahead and move forward with a conversation about the National Diabetes Prevention Program. I hope that our audience has heard of the National Diabetes Prevention Program. It's a wonderful program, and the origins of the National Diabetes Prevention Program actually a clinical trial that was very, very well done. It was a multi-center clinical trial sponsored by the Institutes of Health, and you can see the map here from Seattle down to Florida and a bunch of places in between. They had clinical trial centers. And what the study was designed to do was to see if there's something we can do medication-wise or lifestyle-wise to put the transition to type 2 diabetes from pre-diabetes. So what they did is identified about 3,200 people to participate in this clinical trial. The trial was scheduled to run 4 years, and folks were randomly assigned into one of 3 groups. One group was a lifestyle group, and another group with assistance from nurses and dietitians and exercise specialists. These participants reduce the calorie intake, start to pay attention to what they're eating, and actually ramp up their physical activity with a very moderate goal of achieving 150 minutes of physical activity on a weekly basis. The lifestyle group had a weight loss goal of 7% of their body weight. So that was the arm of the original research. About 1,000 people got the lifestyle intervention. About 1,000 people were randomly assigned to receive metformin, which is a very benign, effective diabetes drug that would put the brakes on the transition from type 2 diabetes. And then the third arm of the group was the placebo group. They got a pill that looked like metformin but wasn't metformin. So everyone essentially compared back to the placebo group relative to type 2 diabetes. The endpoint of this study was who's actually getting type 2 diabetes. And not surprisingly, the people that did not really receive much of a treatment other than a placebo pill advanced to type 2 much more quickly than the people in the lifestyle group or the metformin group. That the study was supposed to run 4 years. The study was actually stopped after 3 years, and clinics are often stopped because of adverse outcomes. In this case, this clinical trial was stopped because of a very positive outcome. What the research study found is people that received a lifestyle intervention reduced their risk for developing diabetes by 58%. People who received the metformin treatment, the diabetes drug, reduced their risk for developing diabetes by 31%. Both are hugely statistically significant. There was a lot of buzz around the study when it came out justifiably. I was in Southern California at the time that the study was published, and I remember reading the LA Times. The front Times had a summary of this really sort of groundbreaking research study. So everybody's really excited about the fact that there's something we could do, either medication-wise or even more lifestyle-wise, to put the brakes on the trend to type 2 diabetes. One of the to this original research, if you want to call it a drawback, was the labor involved in the original research. Lots of one attention with dietitians and nurses and experts. And so scaling this program was a challenge for people because we don't have a nurse, a dietitian, and an exercise specialist for all 86 million of the Americans that have pre-diabetes. So what happened after, well, actually, let me talk a little bit about the DP research study, and then we'll talk about what happened afterwards. What happened, summary, the key point of the DPP research study in terms of the lifestyle intervention, weight loss was one of the most important factors in promoting or putting the brakes on that transition to type 2 diabetes. So weight loss in the context of this study was critical for risk reduction. And keep in mind that weight reduction that the study was after was a 7% weight reduction, which is actually a quite moderate amount of weight loss. It weighs 200 pounds, 7% weight reduction is about 14 pounds. So we're not talking about a huge amount of weight loss to see really positive benefits. Good news is that the effect of weight loss was the same regardless of sex, so male, female, race, ethnicity, and socioeconomic status. So that's something that came with the DP research study. Another strength of the research study was that this study actually performed here in the United States on a population that really reflects what we are in the United States. We're a multicultural, multi-ethnic, and have many different races in our population. 4% of the original cohort could be identified as ethnic minorities. So really well done study. The next relative to the DPP was, well, where can we go from here? We can't give everybody a nurse and a dietitian and an exercise specialist. So we hired, after the publication of the research, which was done in the early 2000s, a nice cohort of translational research where the DP essentially delivered in more group setting. And you see a bullet point here for something called the DEPLOY study. This was a really nice study that was done in the state of Indiana, where they trained YMCA personnel to work with the DPP curriculum to actually deliver the diabetes prevention program. And what they found is they were essentially getting the same weight loss results. So these traditional and actually programs, the Special Diabetes Program for Indians, Diabetes Prevention Demonstration Project, it's been actually going on for over a decade, demonstrating group the DPP curriculum essentially achieving the same weight loss results. Same thing with the state of Montana, very progressive. They have been doing DPP for a number of years now, and the state of Minnesota has also been delivering the DPP in a group format that has been very effective in helping people lose a little bit of weight and reduce their risk for transitioning to type 2 diabetes. So where we are now is the CDC as sponsoring something called the National Diabetes Prevention Program. And the goal of the CDC is to kind of cross-fertilize the DPP, the National Diabetes Prevention Program, across the country. So who's eligible to participate in the DPP? Participate overweight with a BMI of 24 or greater, and if of Asian descent, they can have a BMI of 22 or greater and participate in the program. I get this a lot. Is there anything for teenagers? Is there anything for young kids? DPP. At this point, we don't have anything that is as long as the DPP that is evidence-based as the DPP, which is to say that young people wouldn't benefit from this weight loss and improve physical activity. But at this point, we're looking at adults aged 18 and older. It has to be identified one of ways. It can be diagnosed with a blood test, with a fasting blood sugar, an A1C reading, or possibly an oral glucose tolerance test. If the person has a history of gestational diabetes, they qualify for national DPP if they meet the BMI standard, which in this day and age is not that hard to actually meet. Or they could be identified with as high risk based on a pre-diabetes risk quiz. And there's now a collaborative effort to increase pre-diabetes awareness among the public and providers, and the CDC has a nice pre-diabetes awareness campaign encouraging people to take this risk test. Hopefully, if all the technology goes through, you'll be able to see an example of that public service announcement later in the presentation today. So, DPP goals and structure. The protocols are the same as the original DPP research. Weight loss of 5 to 7% of the starting body weight, and increasing physical activity to 150 minutes a week. And this is done very gradually. The program is structured over the course of a year, and it's kind of divided into 2 6-month sessions. In months, the CDC wants folks to go through the program and take 16 weekly sessions delivered once a week, and that has to happen in the first 6 months. And 16 weekly sessions are consistent with the original DPP curriculum. Essentially, what is being delivered to participants is information that was delivered in the research study. The difference is it's now being delivered in a group format by a lifestyle coach that might be a healthcare professional or might not be a healthcare professional. We get the same results whether it's a healthcare professional or not a healthcare professional delivering the program. For the first 6 months, CDC requirement is that the program be offered at least monthly, and think of the kind of maintenance session to help maintain the gains that they've made during that first 16 weeks or the first 6 months. Program can be delivered monthly, or in our case, at OHSU, we are now delivering the program every other week because we started to see a little bit of focus when we're delivering the program on a monthly basis. Okay. It actually look like, how does it work? It relies on monitoring, goal setting, and the group process. Monitoring goes, program participants track of their weight when they come to class on a weekly basis. They're weighed to weigh themselves when they're at home. They keep track of their food intake. Over time, they initially keep track of fat grams. Everybody's given a fat gram target. And over time, they kind of gradually begin to track calories as well. They also keep track of minutes of physical activity with that long-term goal of working up to 150 minutes of physical activity on a weekly basis. Each a goal is set, or an action plan is set to people work on something for the coming week. And the strength of the national DPP is the group process. The lifestyle coach is trained to facilitate versus lecture, to kind of facilitate a conversation amongst the group to work on problem solving and support change. This is actually what transpires during one of these classes. And what happens is programs are taught certain skills. And as healthcare professionals, a lot of times we know how to look at a food label. We have an idea of what we should be doing with our food. For a lot of people, that's a big mystery. That's news. So time is spent skill building, or healthy eating, and physical activity. And when people are doing the skill building, the focus is very internal. It's an internal focus, paying attention to what's eating, paying attention to how much physical activity I'm doing. As folks move through the program, they transition into other stages. Sessions 8, 9, and 10 are focused on controlling the external environment. You see a session entitled "Take Charge of What's Around You." How do you deal with walking into a movie theater where they're blowing the aroma of hot buttered popcorn up your nostrils? How do you resist buying a giant tub of popcorn and a large soda pop to wash that down? People's unhealthy eating habits are related to problem solving. They've got something going on in their life, and they kind of check out by eating a box of cookies or something like that. How do you go into a restaurant, even a fast food restaurant, and choose something healthy? So we move from kind of the internal skill building to an introduction to the external environment, and then finally focused on addressing the psychological and emotional barriers that people have. And I think we can all relate to challenges where we kind of pacify our stressful days with food or something along those lines. So there's a topic about talking back to negative thoughts. Free slope of lifestyle change is devoted to what do you do when you slip up? We kind of normalize the fact that people are going to slip up, and how do you get back up after a slip? So that's kind of gives you a little bit of a flavor for what goes on in the half of the program, and then we move on to kind of reinforcing those healthy behaviors. And what this will do is this particular map that you see here will give you a feel for where the diabetes prevention program now exists, where trained lifestyle coaches are available to deliver the in-person program. And working very hard with the State Health Department, Andrew Epstein and his shop, to kind of get the word about the National Diabetes Prevention Program and hopefully get some people to deliver the program. That kind of represents counties in the state of Oregon that offer the program in person. Nationally, there are actually a number of vendors that are available to deliver the program virtually. But of course, that virtual delivery comes with a fee. But if you're interested, you can go to just Google National Diabetes Prevention Program, CDC, National Diabetes Prevention Program, and get a feel for delivery organizations and entities across the country and specifically in the state of Oregon. Earlier that the CDC has put together a diabetes awareness campaign, and this is really important. I think this is going to get some traction because a person who has prediabetes, when they have mildly elevated blood sugar, they're essentially asymptomatic. They don't have the classic symptoms of diabetes. They're not thirsty. They're not urinating frequently. Really, the only way they would know something is up is if they have blood tests done because the physician said, yeah, let's check your risk for diabetes. The idea is that 9 out of 10 people, so we're looking at 90% of 86 million people that have prediabetes don't know they have it. So this is a public service campaign that is being put together through the CDC, the Ad Council, and the American Medical Association. I'm hoping that we can play this back in the day.
So we've been having trouble with the audio for this video, but we're going to try to send you the in case this doesn't work. See how it goes. Oh. Okay.
Minute to find out if you may have prediabetes. You can do it here. But you're busy. We're show coming 48 seconds. So let's do this now. Hold up. Wait. Over 60? 100. Mind you're sitting on a couch right now, so wonder if you're not very active. One finger, 0, no. Next, type that looks most like you and hold up that many fingers, walk around awkwardly. And that's 5 fingers or more, probably diabetes. You're just
much, Rebecca, for that PSA. are a couple of other PSAs. The idea is actually to go to the see here, www.doihavepreddiabetes.org, and get people to actually take a look at these PSAs, or actually take a look at this website where they can complete a screening test that will tell them whether they actually are at high risk for having prediabetes. So I'm going to kind of wrap up this portion by talking a little bit about next steps for patient-centered primary care medical homes. For folks, if you're not doing it now, to have a protocol for screening patients for prediabetes. And that's as simple as just doing a fasting blood sugar or an A1C. No fasting required for A1C. If a patient is positive for prediabetes, so they've got an elevated fasting blood sugar or an elevated A1C, refer them to a DPP in your community. If you don't have it in your community, one of your staff trained as a DPP lifestyle coach will potentially coordinate with a local community organization to have one of their staff trained as a lifestyle coach. And there are plenty of DPPs in the community already, and it'd just be maybe a matter of identifying them in your community. As far as additional next steps, the idea is for primary care medical homes to really begin to screen patients and patients in discussion around prediabetes. And there's a RIS website that is listed here. I'm never going to actually be able to go to that website today, but average primary care practice, it's likely that 1/3 of patients over the age of 18 and half of the patients over 65 have prediabetes. This is a from the CDC and the American Medical Association called Prevent Diabetes STAT, which stands for Screen Act Day. So I think I'm running a little bit short on time, and at this point, pass the baton to our facilitator, which I believe is Sarah Worthington in Central Oregon, for her to discuss starting up a diabetes prevention program.
So actually, Sarah is experiencing a fire drill right now.
Of course.
So we have a couple minutes for questions still, and we'll wait and see if she's able to come back on at that time. If not, we can just rearrange and skip to Tracy's section and then move back. We take a few questions. Or do you want to walk through the website?
Happy to, yeah. I wasn't sure because of our technical difficulties, I wasn't able to do that.
So if you go ahead and open up while I'm fielding questions, if you go ahead and open up that website and then your screen, you can show people where you can help navigate them through and talk them through that.
Okay.
So while you're at that, though, we did have a couple of questions about the nutrition focus on fat and calories. Is there any focus on carb identification or consistency?
Sure. That's a great question. The curriculum is not geared towards carbohydrate counting, and I know that that's kind of the state of the art relative to diabetes, and we do those conversations with prediabetes. But our goal is to maintain fidelity to the original research, and the original research was done by limiting fat and calories. And experience as a dietitian has been whenever you give someone some structure, they tend to be successful with it. And so the requirement to the DPP is that we maintain fidelity to the original research. So the focus is on fat grams as a way to limit calorie intake to promote weight loss.
And again, are you home site?
I'm happy with that. So I
can pull it up while I'm asking this question, and I'll just I'll do while you are answering whether DPP programs are covered by Medicaid and Medicare insurances.
Good question. I'll start with Medicare. At this point, there's no coverage for Medicare for the delivery of the DPP, which is not to say that there won't be. On a national level, a lot of effort is being put into getting the DPP covered in the Medicare population, and I think that will be a huge win. As the Medicaid population goes, the Medicaid, almost all of the Medicaid population resides with the coordinated care organizations in the state of Oregon. And some of the CCOs have participated. For example, the Eastern Oregon CCO, the Oregon Educator Benefit Board, has worked to get some lifestyle coaches trained in the eastern part of the state. At this point, we don't have any of the CCOs officially reimbursing for the delivery of the DPP, but we're hard at work with that, talking to the CCOs. Ideally, we'd love to see a situation where there's a referral process and a reimbursement for the delivery of the program.
Thank you for answering that. I think a lot of people are wondering that same question. So I have a couple different sites pulled up. Are you getting my screen done and maybe
I can.
This?
Yeah.
Okay.
Yeah.
On the page, there's also this one.
There we go. That's it. Thank you.
Okay.
Thank you. That's perfect. That's perfect, Rebecca. See if I can. Okay, you'll do it. Okay. So if you want to click on resources for screening, testing, and referral. The document says point of care identification algorithm. What this does is kind of walks you through from start to finish in terms of it's just a flow chart identifying someone with prediabetes. So by having them actually fill out the risk test, we saw the PSA about the risk test, and there's hard copies of the risk test that can be completed. You can take a look at their BMI. Do they qualify? Do they weigh enough? And then the next step would be to actually screen them with an A1C, a fasting blood sugar, or a glucose tolerance test. And then based on the results, you're going to ideally refer the participant to a local diabetes prevention program. So that's just for what goes on with particular human. Rebecca, go back to where we were and open up materials to engage patients, which is, there you go. And pre-diabetes awareness. Simply a poster that could be printed up and put in consult rooms for patients. Reminder both to the providers and to people that could be at risk for having prediabetes. So this is just kind of something that's going to engage the patient. 86 million American adults have prediabetes. Could you be one of them? So that's an example of materials to engage patients. We'll go to one more spot. Finally, materials to share with your colleagues and healthcare team. And this would be, if we open up the one that says evidence behind the diabetes prevention program. It makes a very succinct case for the fact that the evidence-based program for preventing or delaying the transition from prediabetes to type 2 diabetes. So if you need to put an administrator about the program, this would be a nice kind of 2-page summary sheet of the evidence behind it and why it's important to potentially look at this as an intervention for the population. A little bit of a feel for what online resources for you.
Okay, I'm going to chat in the link for these resources so everyone can have access to them. They're also linked on our website, so you can go at your own leisure and download any of these resources. Just want to check and see if Sarah is with us yet. We'll go ahead and jump to, and then we'll come back you. Sarah with us? Sarah's just getting on right now. Let me. Oh, she put herself. Maybe there was just a quick other about whether or not the DPP programs offer transportation services to patients. How intensive this first 6 months require?
Sure. Good question. At this point, I'm not aware of that, but I think that's a brilliant idea if funding to help make that happen.
Okay. Okay. Sarah, are you with us? I see
yes.
When it rains, it pours, right?
Oh my goodness. And I just want to apologize to everyone. Actually, what happened, an announcement came in at 8:28 that we were going to be visited by the fire marshal at 8:30 for a fire drill, and we're still waiting. So could actually interrupt it at any time. I apologize for the confusion. So I'll just dive in and hope that the firemen are running late. Get the opportunity to share a little bit with all of you about our pilot project that we've just started here in January. I'll just start by talking a little bit about our health department. Dukes County Health Services provides public and behavioral health services throughout our county, and this includes Bend, La Paz, Edmond, and Sisters. So with the unit, we have funding from various sources, including the Oregon Health Authority. We have general funds from our county Pacific Source Centers, and this all supports our chronic disease activities, so coordination and administration of Stanford's self-management programs in our Tri-County region. My colleague, Brenda Johnson, and I are both trained leaders, and Brenda is actually also a master trainer, so she travels throughout the state of Oregon to train new leaders in the Stanford self-management programs. Partnerships with many agencies in our area that have really helped us to grow and sustain our offerings. We offer what's listed on the slide here, a chronic disease self-management program, the self-management program, Condo Control, which is the Spanish version of chronic disease self-management, management program in Spanish, and we've just gotten funding to offer Living Well Chronic Pain as well, another Stanford program that we're ready to bring here. So in particular, we've worked with one federally qualified health center here, Medical, to establish electronic health record referrals for patients to these programs. And so this is, it's not been without its kinks, but it has been a tremendous boost to our referral processes for the programs. And I also wanted to mention that in May of 2014, we got Elaine Smiley, and she came to us from the State Health Department in Montana, where, as John mentioned, they've been successfully administering DPP for several years. And many of us have heard her say here that the failure to offer diabetes prevention programs is akin to public health malpractice. In other words, the evidence effectiveness of this program is so robust, and the need is also so great that it is our duty to provide this to our community. So bringing DPP to Central Oregon really has been a major priority for our agency over the last year and a half. So show visually on a map where we administer self-management programs that I just described. When we say the Tri-County region, we're talking about Deschutes along with Craig and Jefferson counties. And we offer our programs in Madras, Prineville, Redmond, and launched. It's really been in the works for some time. We've engaged in many activities to build our capacity to offer this program. Lifestyle Coaches by Don Kane in December of 2014, so it was a while ago. We reached out to others in Oregon and Montana and really spent a lot of time getting some kind of background information to learn from their experiences. We actually developed many proposals for this program, looking at different structures, anywhere from 1 to 3 year programs. So what we were doing is really just laying out the details of how we would put this all together. And then a key development took place when we were awarded the SEARCH grant, or the Sustainable Relationships for Community Health. The goal of SEARCH is to really streamline what we call closed-loop referrals to self-management programs. And this was specifically by bringing together our COs, our coordinated care organizations, and public health agencies together throughout the state. So discussions during these meetings around the diabetes prevention program. And ultimately, we were able to use some of our SEARCH funds to support implementing the actual program. So once that developed place, we began reaching out to our community partners. Our proposal was that each of them would refer patients to this program, and that we would really be committed to providing this program in the initial year at no cost to participants, and also that really we were going to be doing the lion's share of the work. So we needed their help. We really needed the clinic's help getting the patients in the door and identifying the right patients to get in the door. But then we didn't want to burden them with additional detailed implementation. That's really what we were going to take care of. So this first partner for us was Mosaic Medical. And their Redmond clinic, they've been developing a robust panel management workflow for diabetes patients. And we have a key supporter there who is their population health specialist, and she really advocated for this busy agency to help us out. So they provided some staff time to a panel management assistant to identify eligible patients through 2 different processes that I'll talk about in a moment. Another champion was a staff psychologist at St. Charles Family Care in Redmond. Once we talked about this program, she immediately saw the value in it, and she was really interested in bringing this program to her patients. And they've been extremely supportive and actually are providing the conference room space for the class. And it works out very well that their clinic is right next to Mosaic Medical's Redmond clinic. So their space that's very convenient for them. So a little bit more about the process of referral. I provided a collection of resources for each of our partners. We developed brochures for patients, script to help people describe the program, and created fax referral forms, and that included the diagnostic criteria for referral. But the process in each clinic was slightly different. And who is our champion, the psychologist, she presented the program at their provider meeting, and many doctors immediately came on board. Once they received the program information and the forms, I began receiving fax referrals from their providers within a week. They took a different approach. Their clinical applications team ran a report of any patients within their Redmond clinic that have a diagnosis of prediabetes in their chart, and then so create a referral in their EHR so that patient could be directly sent to me through that record referral that we had already had established. The medical director was given a list of the patients that had the diagnosis of prediabetes, and they went through the list and actually highlighted those that believed were good candidates for DPP. So people with diagnosis, but those patients who were sufficiently activated and really kind of motivated enough to take on a commitment like, a year-long program. So they highlighted those, and then after that, their panel management assistant contacted them just to see if they'd be interested in the program before they even sent their information to me. And a note in their EHR would receive their information. So this of running the query, that gave them the base group to start with. Since prediabetes diagnosis is not the only risk factor for eligibility, as Don was talking about, referrals took through office visits. So if a patient had the criteria for DPP having maybe a diagnosis of prediabetes, then a referral would also be placed in the EHR. So referrals came in. I would contact each referred patient to tell them about the program and see if they would like to register. Each about 5 to 15 minutes. So I made sure to inform them about a few key points. The goal of DP, just to make sure they knew what they were getting into, which is 7% weight loss, and how we achieve that, which is through keeping track of healthy eating and working towards that goal of 150 minutes weekly of physical activity. It was a huge help for us in this pilot that we're not charging for the program. So ultimately, we do expect to do so. Also, January, which is a time of year when many people are looking at Weight Watchers or gym memberships, so they could really see this big value to our program, in this case, free. So for each goal, I set up a time to have an intake meeting. Meet for up to half an hour, and I had each person to fill out some forms. The idea behind these intake meetings was really twofold. Because each class is only 1 hour plus weigh-in time, there's value in putting names with faces in advance and letting people know what to expect that first day. It made that first day go much smoother for all of us. And then in addition, we collected some information and had participants sign what I tracked. Form. Just ask for some socioeconomic information, some self-reported medical history, including disabilities, tobacco use, and weight history. And then the second form, the pre-diabetes risk test. And really for that, we actually had a handful of participants who did not have a pre-diabetes diagnosis. So I would have them complete that risk test, which Don mentioned also, so that we have their score on file. And then contract. So this really influenced by motivational interviewing. It's a scale that's just a way to assess readiness or motivation. We ask people to rate the importance of this program and also their level of confidence in being able to complete it. So intake meeting to talk about what is involved in the program on both sides. And while this contract is in no way a binding document, it was just another way for people to think about and demonstrate their commitment. And sometimes people would also tell me about any specific concerns or issues they have. And so as a lifestyle coach, it was really helpful for me to know everyone a little bit in advance. This does have some strict requirements regarding participant data collection and reporting. So we were fortunate to be given access to an online tool that the state of Montana had developed for this purpose. This software also gives us the ability to provide letters that update providers on their patient's progress in the intervals that we're choosing throughout the year. And the Oregon Health Authority is also soon to be launching the Compass online portal, which will be available for agencies throughout the state to manage their self-management programs, including diabetes prevention programs. So that's going to be an incredible resource when it is up and running soon. So about our current state, actually going in to teach our 8th lesson this afternoon. And the 24 patients who were referred in total, we signed up 16. And that first workshop was held on January 27th. That signed up from St. Charles. 6 were that signed up from Mosaic Medical. And then an additional 5 were friends or family members of those referred patients. So it was a really good mix of people. And so we have 11 people still actively attending, and they are really strongly engaged and committed. I don't want to see anyone drop. The size of our group is pretty ideal. 16 was a pretty big group for group participation. Of the 5 people who have dropped since January, 1 got a job, 2 had schedule conflicts arise, 1 requiring intensive treatment, 1 felt overwhelmed with making the changes. So and Central Oregon is really looking bright. We're actively pursuing at Deschutes County Health Services different avenues for securing sustained funding to continue offering the DPP, expand on the current offering, ultimately offering this program in Bend as well as Redmond. And our partners at the Lapine Community Health Center are also preparing to launch a DPP this year, which will really help to fill the gap in the southern portion of our county. And meanwhile, there are staff from both Cook and Jefferson County health departments that are being trained as lifestyle coaches, and they have plans underway for those counties to offer the program in Andros and Prineville. So it's really a super exciting time for us in Central Oregon. We're so delighted to see the rapid expansion of this evidence-based program. It's my portion of the presentation. I'm so glad the fire marshal hasn't barged in yet. And Pepper would like to know if you have any questions. I know we built that in. I'm not sure if we'll have time since we start.
We'll have time for maybe one question, and then we will need to move on. But we do have time at the very end to follow up with any questions if they're still lingering. So one question, let's see, where does it go? When the self-management diabetes leader trainings are, this person would like to know specifically about Washington County, but is there a schedule somewhere that people can access? They can just look up where the local trainings are?
Well, I want to mention Laura Kim at OHA did mention that the system, the Compass portal, did actually go live yesterday, and that will be a great when it's completely with all of the updated information. That will be a great place for people to go and look for information on upcoming leader trainings as well as workshops throughout the state. And I do believe that information is available also on the OHA Living Well website, which look for the link here. I don't have it off the top of my head.
Thank you. That's exciting. And I think Tracy will talk Compass a little bit later in her part of the presentation. And please do continue to type in your questions. If you have questions about Sarah's portion, thank you, Sarah. But we will move on at this point to Don's portion, and we'll come back at the end to any lingering questions.
I'm back again just to talk for a few minutes about diabetes self-management education. And what differentiates the DPP from diabetes self-management education is obviously that diagnosis of diabetes. And diabetes, ask any patient, it's a complex, burdensome chronic disease that requires making numerous daily decisions regarding food, physical activity, medications, and more. Diabetes is in charge of his or his own diabetes 99.9% of the time, and that's the director of our diabetes center, Dr. Andrew Rahman. He says that all the time, and he's a huge advocate for diabetes self-management education because all of the time folks are on their own and they need to know what to do. To me, patients having diabetes feels like a second job. And as a diabetes educator, my job, or our job as diabetes educators, is to be confident in their ability to manage this complex chronic disease. So diabetes self-management education is the process of facilitating the knowledge, skill, and ability necessary for diabetes care. It's a American Diabetes Association that all individuals with diabetes receive diabetes self-management education at diagnosis and as needed thereafter. And I'll make a quick comment here. Diabetes self-management education is not a singular event. It's not you go to diabetes education and you got it. It's really an ongoing process, and people need reinforcement and support. And in a few minutes, Tracy will talk about where that support might come from after the initial diabetes self-management education. But just so that we're clear on what diabetes self-management education might look like, this is to dealing with diabetes in our diabetes center. We refer to this as the diabetes keys to control. We go on and on about family history and genetic predisposition. Patients don't have control over that, but they do have control over things like checking blood sugar. So in diabetes self-management education, we teach people how to use meters. So what do the numbers mean? What are the blood sugar targets? Can we see patterns with blood sugar? We absolutely talk about health diabetes, and a lot of times this involves a conversation about carbohydrate, but we'll also address the comorbidities that come with diabetes, like hypertension and hyperlipidemia. We have a conversation about dietary sodium or saturated fat, something along those lines. The formal delivery of self-management education from a diet perspective is called medical nutrition therapy, and reimbursement, the deliverer of this part of diabetes self-management education needs to be a registered dietitian. We have questions about physical activity. The goal is 150 minutes a week, just like the DPP, but we dig a little deeper and spell out the benefits of regular physical activity and some of the safety issues that might come with regular physical activity and diabetes and medication interaction and so forth. The fourth thing you'll see here is just support in helping people take their medications and helping them to understand what their medications are actually doing in their bodies and why it's critical for them to take their medication. And then the final thing that, which is a critical part of diabetes self-management education, is support. Support from family, friends, healthcare providers. We've got a whole village of people that really need to support the person with diabetes. Delivers diabetes self-management education. Traditionally, it's done by a nurse, a dietitian, or pharmacist, or potentially another trained or credentialed healthcare professional. And ideally, we'd like people to be working, either have or be working towards becoming a certified diabetes educator. But diabetes self-management education does not reside solely with the diabetes educator. Practice-based care managers, social workers, mental health counselors, community health workers, peer and family members, all of those people are important components. Diabetes education is not necessarily owned by the provider or the diabetes educator. Everybody is helping with diabetes education. Self-management education reimbursable is provided you the appropriate credentials, and there are three accrediting bodies. The American Diabetes Association, well, the process you can go through to become an accredited provider of diabetes self-management education. Service has a parallel offering as the American Association of Diabetes Educators. So all of these entities relationships with the CMS, the Centers for Medicare and Medicaid Services, that say we'll deliver or we will reimburse for the delivery of diabetes self-management education provided you're an accredited organization. Diabetes self-management education reimbursable services, I mentioned this a little bit earlier. Medical nutrition therapy provided by a registered dietitian is reimbursable. So at a minimum, most hospitals in regions across the state have dietitians on their staff, and you can refer a patient to a dietitian, and that dietitian can in turn bill care or corresponding insurance company. What we've noticed is that insurance providers usually kind of follow Medicare. Whatever Medicare brings for, a lot of insurance pay fall in line with that. And so that was a great question earlier about Medicaid reimbursing and Medicare reimbursing for the DPP. I think once Medicare is valuable or worthwhile for the DPP, we're going to see a whole slew of other entities reimbursing for the diabetes prevention program. Reimbursement can be delivered to pharmacists as well as to a mental health care professional related to diabetes self-management education. So I want to offer diabetes education. It does work. In a word, diabetes education works in most cases really, really well. We see improvements in A1C. If we can get it in the game and get people to control their blood sugar, there's a decreased risk for the advancement of diabetes complications. People go through diabetes education, they feel better about themselves, they feel better about their ability to manage their condition. They go through diabetes education, they tend to eat better, they engage in regular physical activity more frequently. This bullet point here is critical. Diabetes self-management education enhances self-efficacy and empowerment. I think that truly health professionals are in the self-efficacy business, if you will, and the goal is to get people confident and comfortable with this condition called diabetes. That receive diabetes education, cope with it better, and they have less diabetes-related distress and depression. So, get diabetes self-management education actually get it? I would say the answer to that is probably not. It's really unfortunate. The number of people who receive formal diabetes self-management education is quite low. 6.8% of newly diagnosed people, new onset diabetes, receive diabetes self-management education from their private health insurance. It's out there, just I think that a lot of times maybe the provider or the participant doesn't know that this is available to them. And then the other statistic that's unfortunate is that only 4% of eligible Medicare participants take advantage of diabetes self-management education. So I think there's some work to do in terms of just making people with diabetes aware that this is available to them. So what this slide has is a couple of links, and we won't mess around with going into these links, but in order for reimbursement to take place for diabetes self-management education to an accredited program, a referral must first come from a healthcare provider, which is kind of standard practice for most visits with a dietitian or a diabetes educator. What you hear, and when you get a chance, you can click on these links, how you can locate a local diabetes self-management education provider near you. The first is to American Diabetes Association accredited programs, and the second link is to the American Association of Diabetes Educators diabetes self-management education programs. And both of these have very searchable functions. You can search by zip code, you can search by city and state to see if there's a local diabetes self-management education provider near you. And this discussion by saying that diabetes is a complex and burdensome disease. In order for people to be effective self-managers from diabetes self-management education. Diabetes self-management education lays the foundation for taking care of oneself, but it requires that ongoing support to maintain the gains that have been made during diabetes education. And we can see that diabetes self-management education is an ongoing process that requires support to maintain healthy behaviors. An example of diabetes self-management education support could come in the form of the diabetes self-management program from Stanford University. At this point, I think the plan is to turn it over to Tracy Carver to give you a feel for what goes on with the diabetes management program from Stanford.
This is Tracy, and as you can probably hear, I have laryngitis, so I apologize, my voice isn't very pleasant. And I've asked our clinical director, Nicole O'Kane, to join me in case my voice completely goes. So I am going to talk to you a little bit about the Stanford University Diabetes Self-Management Program. Get into the details of the program itself. I wanted to take a moment to, everybody on the phone is familiar with who we are. I'm Acumentra Health, and we're part of the Health Insight Medicare Quality Innovation Network. And in this role, we lead Medicare's quality improvement initiatives for the state of Oregon, and providing this resource since 1984. Our current contract with Medicare, one of our areas of focus is to promote and implement a national initiative called the Everyone with Diabetes Counts Initiative. This is a nationwide endeavor to improve diabetes care and increase access to diabetes self-management education, particularly in underserved communities. Diabetes self-management education, as it's defined through this initiative, is both the accredited programs that Dawn just shared, as well as the diabetes self-management program, which I'll talk about in a moment. We provide support to clinical partners around improving referral pathways into diabetes self-management education, and as well as helping clinics to improve diabetes care and monitoring, as well as optimizing their ability to bill for SMT, as well as the medical nutrition therapy, which Dawn touched on. And SMT, I apologize, that's diabetes self-management training, which is a code that is used by Medicare to pay for the diabetes self-management education provided by accredited programs. Now, in a little bit more detail about the Stanford Diabetes Self-Management Program, and I think Dawn did a really nice job setting up context of how this program fits into the patient's support services as it relates to managing their disease. The Self-Management Program is a 6-week workshop series that was developed by Stanford University to help patients obtain the skills they need to be effective self-managers. This program is one of a suite of programs available from Stanford for chronic disease self-management. They're facilitated by 2 trained and certified leaders who are under the oversight of an organization that is licensed through Stanford. Leaders can be health professionals, but they are not required to be, and in fact, Stanford often encourages at least one of the leaders be a peer leader with diabetes themselves. And on the slide, these programs are 2.5 hours a week, and I'm going to go in a moment to talk in a little more detail about the curriculum, but one thing to know about these programs is that the reason 2.5 hours a week is because they're highly participative and they really focus around helping teach patients how to have the tools they need to improve their self-management. So 2 different domains in which the curriculum of the Diabetes Self-Management Program falls. One is around the actual education that participants receive when attending the Diabetes Self-Management Program. The education in the module aligns with the 7 self-care behaviors that are identified by the American Association of Diabetes Educators. And you can see those here on the screen. So they're healthy eating, being active, monitoring, healthy coping, reducing risk, taking medications, and problem solving. It does not replace, but rather reinforces and complements the education that patients are receiving from their providers as well as from accredited diabetes self-management programs. Stan regularly reviews the training curriculum and provides update training to the master trainers who then ensure that all the leaders under their purview receive those updates on a regular basis to ensure that the that participants receive continues to be in alignment with current guidelines. So now I see the real magic of the Diabetes Self-Management Program. The Self-Management Program teaches participants using the concept of a self-management toolbox, which you can see here. This is shown to be effective in teaching participants how to think about and apply self-management skills to a variety of situations they may encounter when managing their chronic conditions. And this toolbox is actually used in all of Stanford's programs, which Sarah shared with you on her slide, the chronic disease program as well as the pain program and the Spanish versions. Participants practice these skills in a highly interactive environment and help others and help from others in applying the toolbox to help them troubleshoot challenges they may encounter each week. As part of this process, patients are taught how to goal set and then make action plans each week for how they're going to reach their goal. And in the time that they're together, they come back and they share their action plans and work as a group to identify ways in which the participant might modify their action plan that given week in order to be more successful next week if they were to encounter barriers. So at the end of the slide deck, there's a resource slide that has several studies listed on it that you can look up from Stanford. But I thought that in the time I have today, you would be more interested in seeing a little bit of the early data that we've been collecting for Oregon, specifically the Diabetes Self-Management Program. Since this program's been around for a while, it's internationally utilized, but those studies are available to you if you're interested. So part of our national initiative through our Medicare work, we have been collecting pre- and post-survey data for diabetes self-management programs in several communities across the state. Workshop data that I'm going to share with you today comes from programs that were held in 2015, and we, in that time, collected data on 11 workshops, of which we had 106 participants and 73 graduates. A person considered to have graduated from the program if they've taken at least 4 of 6 things, and that is a bar that was set by Stanford as the amount of work or series that a participant needs to complete in order to receive the benefits of the program. In addition to this data, as we move forward, we're going to continue collecting this data and roll into an aggregate report, as well as providing community-based reports back to the licensed organizations on just their workshops. We're also just now at the start of the process of collecting clinical data on a set of the care fee-for-service beneficiaries who complete the program, and are hopeful to have enough volume to start to include that in the report as well. Okay, survey. I'd like to share briefly some information about the kinds of self-reported health conditions that participants were reported during these 11 workshops. As you can see, I apologize, the text is tiny. 79% of participants reported having diabetes, and we had about 10% report having prediabetes. While the program is not designed for prediabetes and the DPP is the better option, there are instances where these folks come, particularly in more rural areas, if they are not able to access other resources. We also have about 5% who report no chronic conditions, which we're attributing to caregivers, and often we do caregivers come with the person with diabetes to help support them in their journey, and that's been a great model. I also wanted to point out that about 25% reported having depression or anxiety disorder, and I want to point this out because we know that people with diabetes are at a greater risk of developing depression, so it will be interesting to watch as we continue to collect more data through 2019 to watch these numbers grow and change. So I'm going to share a few examples of the kinds of questions that we ask of participants. In all, there are 14 questions on the survey, but I'm just going to share information from 3 today. And I see that I'm a little short on time, so do you want me to continue or skip?
It looks like most people's questions are being answered in the chat, so
okay.
I think we can just sort of breeze through.
Okay, try and be efficient. So this first question, I just chose a couple of questions to show you some of the initial trends that we're seeing in our Oregon data from the participants who are completing the Diabetes Self-Management Program. First question, we asked patients if they could make a plan to control, that would control their diabetes. Class, 60% reported yes, I can make a plan to help control diabetes, and following completion of the work series, that jumped to 90%, and this was statistically significant gain. So we were excited to see that even in our first year and relatively small sample size. That one of the main focuses of the workshop, as I mentioned before, is teaching goal setting and action planning, and so I think that it's really reinforces what we already know about this program being effective. The question I wanted to share was how patients reported to the question about knowing healthy ways to manage their stress. We saw a similar trend of significant improvement in this question as well, with 4% reporting that they felt, yes, they knew healthy to manage their stress before they took the workshop series, jumping to 85% who reported confidence in knowing ways to handle their stress after. And this one, which I thought would be of particular interest to this audience, was how patients were feeling as asking their doctors questions about their treatment plan. The jump looks a little bit smaller on this slide, with 85% reporting confidence in asking their doctor questions before the workshop series and 98% following. We did find this was a statistically significant gain. We continue to monitor this data and report it. As our sample size grows, as I mentioned, we'll be collecting this data through probably midway through 2019. Our contract ends July 2019, and we'll be producing reports as well as giving communities back their data at a local level report. Okay, if you'd like more information about where you can find a diabetes program in your community to refer to, Compass will have a nice interface that you can go on to look up workshops. We also offer on our website a list of upcoming workshops by county, which you can see the link here. We keep that up to date weekly. And if there are not any workshops listed in your county, we've done our best to provide the name and information of a coordinator. If you're still having trouble finding out information, please do contact us, or if you have interest in getting program capacity grown in your region, please contact us. Map to show you generally where there are programs, or rather there are currently trained leaders that can offer the diabetes self-management program in Oregon. There are a few additional counties on here that aren't blue yet, but are working on building capacity. So again, this map will continue to grow. Just quickly wanted to roll our presentations together to give you an idea of how these support services might fit on the continuum of a patient's self-management over time. So as Dawn shared, the diabetes prevention program very clearly fits the pre-diabetes population. For those that move into diabetes, which we hope less and less will, diabetes self-management training is actually in reference to the accredited programs that Dawn shared, and the diabetes self-management program can fit nicely in complement to that. As we heard, this is more of an optimal flow where patients receive the initial 10 hours at new onset, and then they can attend the diabetes self-management program while also receiving the 2-hour annual follow-up that can be billed to Medicare. However, in some instances in more rural communities or in areas where maybe access is more difficult, patients can attend the diabetes self-management program while they wait to see the certified diabetes educator. So it's a hard line. They are interchangeable to meet the local needs. And I'm going to stop there because I know that we're close to time. I will see you, Becca. Thank you. And I apologize for the voice.
Thank you, and thank you, Sarah and Dawn, and also thank you to everyone for being on this webinar with us and hanging through some of the technical difficulties. And I appreciate that everyone.
That there have been people.
Appreciate that that people have been chatting answers to our questions. I think the question we still had was that some of these are linking to other programs such as the CC Million Hearts campaign, which includes diabetes measures, just to help see themselves more holistically.
I know at least the diabetes prevention program is not directly linked to that program.
So this is Tracy. While we don't do a direct link per se, we also support the Million Hearts campaign at Acumentra. So we work with clinics across a variety of topics related to Million Hearts, diabetes, quality reporting, behavioral health, and we do work here to do our best to really align our education and resources so that it is seen more as a package and not just these siloed initiatives. So if you're interested in receiving support from that, please contact me and I can help connect you with the resources here.
And I promised that we'd get out of here right on time, and it is just 1 minute past. So you have the email addresses here for all of our presenters. Thank you again, Tracy, Dawn, and Sarah. And on the next 2 slides, which we will make available on our website, there are several additional resources. We'll include all of the links that were mentioned in the webinar today. And just to please to the post-webinar survey, and other than that, thank you so much. Have a great rest of your day.